Welcome to our YouTube lecture on endodontics in dental trauma. In this video, we'll explore how endodontics plays a crucial role in treating dental injuries. We'll cover the common types of dental trauma, the use of cone beam computed tomography, CBCT, in diagnosis, and specific treatments like vital pulp therapy. From crown fractures to root resorption, we'll discuss diagnosis, clinical presentation, and management strategies. Join us as we navigate through the complexities of dental trauma and the vital role of endodontics in restoring dental health. Traumatic injury to the tooth results in damage to dental and periradicular structures. Management and consequences are multifactorial. Understanding healing patterns of these tissues is crucial. Unique aspects of dental trauma. Most common in the 7 to 12-year-old age group. Mainly caused by falls and accidents near home or school. Primarily affects the anterior region of the mouth, with the maxillary jaw being more susceptible. Serious accidents, like automobile crashes, can affect any tooth and occur in all age ranges. Endodontic treatment after traumatic dental injury. Often provided to caries-free, single-rooted, young permanent teeth. Quick and correct treatment post-injury leads to a high potential for successful endodontic outcomes. Most common types of dental trauma. Crown fractures. Often occur in young, caries-free anterior teeth. Vital pulp therapy, crucial for maintaining or regaining pulp vitality. Crown root fractures. Initially treated periodontally to ensure a sufficient margin for restoration. Pulp treatment follows if tooth can be maintained from a periodontal perspective. Root fractures. Surprisingly, many pulps in root fractured teeth survive. Apical segment usually remains vital, coronal segment may regain vitality or become non-vital. Luxation injuries and avulsion often lead to pulp necrosis and damage to the cemental protective layer. Potential complication of pulp infection in a root lacking cemental protection. Timely emergency and follow-up evaluation, including endodontic treatment, is critical. Treatment and prognosis. Correct treatment and procedures are essential for a good prognosis. Vital pulp therapy supports favorable outcomes in crown fractures. Periodontal assessment is crucial for crown root fractures. Prompt evaluation and intervention reduce complications in luxation injuries and avulsion. Interpretation of pulp tests on traumatized teeth. Thermal and electric tests provide generalized impressions post-trauma. Sensitivity tests for nerve function, not indicators of blood circulation. Traumatized teeth may yield false negative readings due to deranged nerve impulse conduction. At initial examination doesn't guarantee long-term health. No response doesn't confirm necrotic pulps. Follow-up protocol. Thermal and electric pulp tests should be conducted initially and recorded. Tests repeated at intervals, 2 to 4 weeks, 6 to 8 weeks, 3 months, 6 months, and yearly thereafter. Carbon dioxide snow or dichlorodifluoromethane on facial incisal third for more accurate responses. Avoid water ice pencils due to potential false positive responses. Electrical pulp tests useful when dentinal tubules are closed, as in elderly patients traumatized teeth undergoing premature sclerosis. Signs of pulp health. Transition from negative to positive response at subsequent tests indicates healing pulp. Repetitious findings of responses suggest a healthy pulp. Transition from response to no response may indicate pulp degeneration, potentially requiring endodontic treatment. Persistence of no response suggests irreversible damage, but not absolute. Use of cold tests in trauma evaluation. Intense cold penetrates tooth and restorations, reaching deeper areas. Dry ice and dichlorodifluoromethane spray avoid forming ice water, preventing false positive responses. Water ice pencils should be avoided in trauma evaluation due to potential false positives. Dichlorodifluoromethane spray is a cost-effective alternative to CO2 snow, providing more reliable responses. Role of electrical pulp test. Relies on electrical impulses to stimulate pulp nerves. Limited value in young teeth. Useful when dentinal tubules are preventing dentinal fluid flow, as in elderly patients or traumatized teeth undergoing premature sclerosis. Particularly important when thermal tests relying on fluid flow in tubules cannot be used. Laser Doppler flowmetry, LDF. Introduced in the early 1970s for measuring blood flow in the retina. Also used to assess blood flow in other tissue systems like skin and renal cortex. Utilizes a beam of infrared or near-infrared light directed into tissue via optical fibers. Light scattered by moving red blood cells undergoes frequency shifts according to the Doppler principle. Light scattered by stationary tissue cells is not Doppler shifted. A portion of the scattered light is returned to a photodetector, producing a signal. Application in dental trauma. Attempts made to use LDF for pulp vitality diagnosis in traumatized teeth. Offers more accurate readings of pulp vitality status. Studies show promising results, detecting blood flow earlier and more consistently than standard vitality tests. Can detect blood flow as early as 2 to 3 weeks post-avulsion in immature teeth. Limitations. Cost of LDF machine limits its use in private dental offices. Primarily used in hospitals and teaching institutions presently. Role of radiographic examinations. Essential for thorough examination, diagnosis, and management of dentoalveolar trauma. Reveals various conditions such as root fractures, crown fractures, tooth displacements, bone fractures, root resorptions, and foreign objects. Single radiograph, including panoramic images, is insufficient for proper diagnosis in most dental trauma cases. Guidelines for radiographic examinations. International Association of Dental Traumatology, IADT, recommends taking at least 4 different radiographs for almost every injury. Recommended radiographs. Direct 90-degree image on the axis of the tooth. 2 images with different vertical angulations. 1 occlusal film. Importance of compliance. Following these guidelines ensures comprehensive assessment and accurate diagnosis of dental trauma cases. Limitations of 2-dimensional, 2D, radiographic imaging. Lack of 3-dimensional, 3D, information may hinder proper diagnosis and affect treatment outcomes. Superimposition of teeth and surrounding structures can confound interpretation. Periapical radiographs offer only a limited 2D of true 3D anatomy. Geometric distortion is common in conventional radiographic methods. Advantages of cone beam computed tomography, CBCT. Overcomes limitations of 2D imaging. Produces accurate 3D images of teeth and surrounding structures. Diagnosis of luxation injuries, alveolar fractures, root fractures, and root resorption. Role of radiography in soft tissue laceration. Radiograph the injured area before suturing to detect embedded foreign objects. Soft tissue radiograph with reduced kilovoltage exposure can reveal foreign substance, including tooth fragments. Patient sustained, complicated. Crown fractures on the left lower incisors and later on the canine tooth. An emergency pulp capping, Band-Aid composite was placed on the teeth. 6 days later, the patient was referred to the clinic because of a poorly healed laceration on the lip. Radiograph of the lip revealed a portion of the lateral crown still in the lip. Cone beam computed tomography, CBCT, for dentoalveolar trauma. Utilizes a rotating gantry with fixed X-ray source and detector. Divergent pyramidal or cone-shaped radiation directed through area of interest onto opposite X-ray detector. Source and detector rotate around a fixed fulcrum, acquiring hundreds of planar projection images in an arc of at least 180 degrees. Single rotation provides precise, immediate, and accurate 3D radiographic images. CBCT exposure covers entire field of view, requiring only one rotational sequence for image reconstruction. Advantages and recommendations. CBCT suggested as adjunct imaging tool when true nature of dentoalveolar injuries cannot be confidently diagnosed from conventional examination and radiographs. demonstrated to provide improved diagnostic images in cases of dentoalveolar injury. Considered best practice recommended for most serious injuries. A. Panoramic radiograph taken on a patient with past history of dentoalveolar trauma. Tooth number 9 appeared to have arrested root development with a periapical radiolucency. B. Sagittal view of tooth number 9 of same patient from CBCT imaging. That tooth number 9 had arrested root development, a large PA radiolucency, and extensive root resorption along the palatal surface that was not evident on the panoramic image. C. Periapical radiograph of tooth number 9 with extensive complicated crown fracture. The clinical examination revealed the fracture extended subgingivally on the palatal aspect. D. Sagittal view of tooth number 9 of same patient from CBCT imaging. This revealed that the apical extent of the fractured palatal portion extended just apical to the crest of bone. The correct diagnosis of this injury was complicated crown root fracture. E. Periapical radiograph of teeth. Number 8, number 9 revealed crown fractures. F. Sagittal view of tooth number 9 of same patient from CBCT imaging. This revealed that tooth number 9 suffered a lateral displacement injury with extensive concomitant alveolar fracture. The necessary treatment of repositioning and splinting was apparent. Detection of root resorption. Early detection challenging due to lack of clinical signs. Definitive diagnosis relies on radiographic demonstration. Radiodensity of root requires significant resorption for contrast on radiograph. Resorptive defects on mesial or distal aspect more predictably detected. Facial and palatal/lingual aspects harder to visualize. Multiple horizontal angled radiographs recommended for suspected root resorption. CBCT improves detection and assessment of resorptive defects compared to conventional radiographs. Horizontal root fracture. Risk of misdiagnosis with intraoral radiography due to oblique course of fracture line. CBCT enables earlier detection and assessment of horizontal root fractures. Provides coronal, axial, and cross-sectional views for accurate diagnosis. Luxation injuries. Conventional intraoral radiography has poor sensitivity for detecting minimal tooth displacements and root/alveolar fractures. CBCT significantly improves accuracy in diagnosing traumatic injuries, overcoming limitations of plain film projection. Crown infraction. Definition: incomplete fracture or crack in enamel without loss of tooth structure. Biologic consequences: little danger of pulp necrosis. Meticulous follow-up over 5-year period is crucial for preventive endodontic measures. Any changes in sensitivity tests or of apical or pararadicular periodontitis on radiographic assessment warrant endodontic intervention consideration. Uncomplicated crown fracture. Definition: fracture of enamel only or enamel and dentin without pulp exposure. Incidence: most commonly reported dental injury, accounting for 1/2 of all reported dental trauma. Biologic consequences: little danger of pulp necrosis, main risk is iatrogenic causes during aesthetic restoration. Treatment: close exposed dental tubules promptly. If broken piece unavailable for reattachment, place composite band-aid or temp coverage to prevent bacterial ingress and reduce discomfort. If remaining dentin thickness greater than 0.5 mm, restore tooth with preferred restoration method without special attention to pulp. If remaining dentin thickness less than 0.5 mm, apply protective layer of hard-setting calcium hydroxide to reduce or prevent reactive inflammation of underlying pulp. Complicated crown fracture. Definition: involves enamel, dentin, and pulp. Incidence: occurs in 0.9% to 13% of all dental injuries. Biologic consequences: without treatment, always leads to pulp necrosis. Initial reaction after injury is hemorrhage and local inflammation, followed by proliferative or destructive inflammatory changes. Proliferative response expected within 24 hours, with inflammation extending up to 2 mm into pulp. Treatment options. Vital pulp therapy, pulp capping, partial pulpotomy, or full pulpotomy. Pulpectomy, removal of pulp. Choice of treatment depends on stage of tooth development, time between trauma and treatment, concomitant periodontal injury, restorative treatment plan. Factors influencing treatment choice, stage of tooth development. Vitality crucial in immature teeth to prevent catastrophic consequences. Vital pulp therapy preferred to maintain vitality until apex and cervical root complete development. Time between trauma and treatment. Proliferative roots within first 48 hours, chances of maintaining healthy pulp decrease with time. Concomitant attachment damage, periodontal injury compromises pulp nutritional supply, affecting pulp survival. Restorative treatment plan. Simple restoration, vital pulp therapy may suffice. Complex restoration, pulpectomy may be more predictable. Requirements for successful vital pulp therapy. Treatment of non-inflamed pulp. Vital for successful therapy. Optimal time for treatment is within first 24 hours to address superficial inflammation. As time increases between injury and therapy, pulp removal must extend apically to reach non-inflamed pulp. Bacteria-tight seal. Critical factor for success. Effective sealing prevents bacterial challenge during healing phase, ensuring successful healing of pulp with hard tissue barrier. Independent of dressing placed on pulp. Pulp dressing. Traditionally, calcium hydroxide used for its antibacterial properties and ability to disinfect superficial pulp. Pure calcium hydroxide causes necrosis of approximately 1.5 mm of pulp tissue, removing superficial layers of inflamed pulp. High pH of calcium hydroxide causes liquefaction necrosis superficial layers, leading to coagulative necrosis at junction of necrotic and vital pulp, resulting in mild irritation and inflammatory response. Calcium hydroxide does not seal fractured surface, requiring additional material for bacterial protection. Bioceramic materials, such as mineral triacate, MTA, and newer generation bioceramic materials e.g., biodentine, considered superior to calcium hydroxide for traumatic pulp exposures due to their properties and lack of disadvantages associated with calcium hydroxide. Pulp capping. Definition: placing dressing directly on pulp exposure without tissue removal. Indications. Few indications for traumatic pulp exposures due to lower success rate, 80%, compared to partial pulpotomy, 95%. Superficial pulp capping not recommended due to development of superficial inflammation soon after exposure. Difficulty in achieving bacteria-tight seal with superficial pulp capping. Early studies suggested amalgam as standard coronal restoration may contribute to poor results due to microleakage. Recent studies suggest bioceramic materials may provide more success even with inflamed pulp, emphasizing importance of coronal seal. In cases of traumatic pulp exposure within 48 hours, superficial inflammation, removal of superficial inflammation and placement of bioceramic agent for pulp capping may be considered. Partial pulpotomy, pulpotomy. Definition: removal of coronal pulp tissue to the level of healthy pulp. Indications. Similar to pulp capping. Technique. Administration of anesthetic, rubber dam placement, and superficial disinfection. Preparation of 1 to 2 mm deep cavity into pulp using high-speed handpiece with sterile diamond burr. Deeper amputation if bleeding is excessive until moderate hemorrhage is seen. Removal of excess blood with sterile saline, drying with sterile cotton pellet. Rinse with 5% sodium hypochlorite, NaOL, for chemical amputation of blood coagulum and hemorrhage control. Calcium hydroxide placement on pulp stump, or commercial hard-setting calcium hydroxide if pulp size doesn't permit further loss. Fill cavity with material for bacteria-tight seal, e.g., glass ionomer cement, followed by resin with bonded composite resin. Alternatively, cap pulp with MTA, cover with lining material, and restore with composite resin may cause discoloration. Follow-up. Similar to pulp capping, with emphasis on maintenance of sensitivity test responses and radiographic evidence of continued development. Prognosis. Advantages over pulp capping, removal of superficial inflamed pulp, disinfection with calcium hydroxide, and provision of space for bacteriotite seal. Extremely good prognosis, 94% to 96%. Kvek partial pulpotomy. A. The fractured teeth are cleaned and disinfected, a rubber dam is placed. B. Cavities are prepared at high speed with a round diamond bore 1 to 2 mm into the pulpal tissue. C. Calcium hydroxide on a plugger, D, is placed on the soft tissue of the pulp. E. Care is taken to avoid smearing the walls of the preparation with the calcium hydroxide. F. Cavity preparations are filled with glass ionomer cement. The exposed dentin is etched, G, and then covered with composite resin, H. I. Radiograph 6 months later shows formation of hard tissue barriers in both teeth. Full pulpotomy. Definition: removal of the entire coronal pulp to the level of the root orifices. Indications: when inflammation is anticipated to extend deeper into the coronal pulp. Traumatic exposures after more than 72 hours. Carious exposure of a young with a partially developed apex. Technique: administration of anesthetic, rubber dam placement, and superficial disinfection. Removal of coronal pulp to the level of root orifices. Application of calcium hydroxide dressing, bacteriotite seal, and coronal restoration. Follow-up, similar to pulp capping and partial pulpotomy. Radiographic follow-up is crucial due to inability to conduct sensitivity testing. Prognosis. Prognosis is around 75% due to potential mistakes in treating inflamed pulp. Sensitivity testing is not possible. Radiographic follow-up essential. Some authors recommend routine pulpectomy after full pulpotomy when roots have fully formed, as pulpectomy has a higher success rate. Pulpectomy. Definition: removal of the entire pulp to the level of the apical foramen. Indications: complicated crown fracture of mature teeth. Conditions not suitable for vital pulp therapy. Need for post-placement during restoration. Treatment of non-vital pulp mature teeth, apexification. Indications: open apices. Thin dentinal walls hindering standard instrumentation. Biologic consequences. Challenges in endodontic treatment due to wider apical canal, lack of apical stop, and susceptibility to fracture. Technique: disinfection of the canal using 0.5% NaOCl. Estimation of canal length with preoperative radiograph. Light filing with copious irrigation. Use of creamy mix, calcium hydroxide applied for at least 1 week. Treatment continue within 1 month to prevent calcium hydroxide washout. Considerations: reinforcing the weakened root against fracture during and after apexification. Hard tissue apical barrier. 1. Traditional method. Procedure: calcium hydroxide used to initiate hard tissue formation at the apex. Calcium hydroxide packed against the apical soft tissue. Canal backfilled with calcium hydroxide. Regular evaluation through radiographs to assess for hard tissue barrier formation and calcium hydroxide washout. Advantages: predictable hard tissue barrier formation. Disadvantages: long treatment duration, 3 to 18 months. Potential for root weakening with prolonged calcium hydroxide use. 2. Bioceramic barrier. Procedure: bioceramic material used for quick hard tissue barrier formation after canal disinfection. Calcium sulfate pushed through the apex as a resorbable extraradicular barrier. Bioceramic material packed into the apical 4 to 5 mm of the canal. Canal filled with thermoplasticized gutta percha. Cervical canal reinforced with composite resin. Advantages: rapid hard tissue barrier formation. Case reports and efficacy. Growing popularity among clinicians. Numerous reports supporting efficacy of the technique. Apexification with mineral trioxide aggregate, MTA. A. The canal is disinfected with light instrumentation, copious irrigation, and a creamy mix of calcium hydroxide for 1 month. B. Calcium sulfate is placed through the apex as a barrier against which the MTA is placed. C. A 4 mm MTA plug is placed at the apex. D. The body of the canal is filled with the Resolin obturation system. E. A bonded resin is placed below the cement-enamel junction, CJ, to strengthen the root. Filling the root canal. Softened filling technique. Apical diameter often larger than coronal diameter. Care needed to avoid excessive lateral force due to thin root walls. Hard tissue barrier formation. Consists of irregularly arranged layers of coagulated soft tissue, tissue, and cementum-like tissue. May have a Swiss cheese consistency with islands of soft connective tissue. Cement or softened filling material might be pushed through the barrier during filling. Barrier formation may be short of the radiographic apex. Reinforcement of thin dentinal walls. Thin walls pose a risk of fracture during or after treatment. Intercoronal bonded restorations can increase resistance to fracture. Bonded resin filling placed below the marginal bone level after root filling. Follow-up. Routine recall evaluations to assess prevention or treatment of apical periitis. Ensure restorative procedures do not promote root fractures. Prognosis. Periapical healing and hard tissue barrier formation predictable with long-term calcium hydroxide treatment, 79% to 96% success rate. Long-term survival jeopardized by fracture potential in dentinal walls. Newer techniques of internally strengthening teeth expected to increase long-term survivability. Pulp revascularization/regenerative endodontic treatment. Advantages. Potential for further root development and reinforcement of dentinal walls. New tissue growth into the pulp space. Crown intact and caries-free, slowing bacterial penetration into the pulp space. Regeneration process. Effective disinfection of the canal. Provision of a matrix for new tissue growth. Effective sealing of coronal access. Outcome measures for success. Elimination of symptoms and evidence of bony healing. Increased root wall thickness and/or length. Positive response to vitality testing. Disinfection protocol. No mechanical preparation, but copious irrigation with NaOCl. Intercanal mixture of antibiotics or calcium hydroxide as medicament. Considerations to avoid crown discoloration. Future directions. Research on synthetic matrix for tissue ingrowth. Exploration of stem cells and growth factors for odontoblast production. Tissue engineering for achieving true pulp regeneration. Clinical application. Recommended for immature teeth with incomplete root formation. Conventional endodontic therapy recommended for mature teeth with closed apex. Follow-up and treatment adjustment. If no signs of regeneration or continued infection, traditional treatment methods can be initiated for immature teeth. Note, regenerative endodontic treatment holds promise for pulp regeneration but has variable outcomes, especially in achieving true pulp/dentiflex regeneration. Further research is ongoing to enhance predictability and efficacy. Crown root fracture. Periodontal challenge. Treatment focuses on periodontal care to enable a well-sealed coronal restoration. Options include gingivectomy or orthodontic/surgical extrusion to make the root fracture surface treatable. Coronal restoration. Once feasibility of coronal restoration is ensured, treat the crown fracture as described previously. Root fracture. Frequency. Relatively infrequent, occurring in less than 3% of all dental injuries. Characteristics. In immature teeth with vital pulps, horizontal root fractures are rare. Coronally displaced segment, apical segment typically remains undisplaced. Rare disruption of apical pulpal circulation, leading to minimal risk of pulp necrosis in the apical segment. Endodontic considerations. Permanent pulpal necrosis of the coronal segment occurs in approximately 25% of cases, necessitating endodontic treatment. Diagnosis and clinical presentation. Similarity to luxation injuries. Clinical presentation resembles luxation injuries. Degree of displacement of coronal segment indicates fracture location. None, apical fracture, simulates concussion injury. Severe, cervical fracture, simulates extrusive luxation. Importance of radiographic examination. Root fractures are often oblique, facial, to palatal. Periapical radiographs may miss fractures. Take at least 3 angled radiographs to visualize the fracture line. Treatment. Emergency management. Reposition segments into close proximity. If coronal segment is severely displaced and lodged in cortical bone, gently pull it downward to release from bone. Once loose, rotate it back to original position. Splinting protocol. Traditionally recommended 2 to 4 months with rigid splinting. Current approach. Flexible splint to adjacent teeth for 2 to 4 weeks. Prognosis. Delay between injury and treatment compromises long-term prognosis. Healing patterns of root fractures. Healing with calcified tissue. Radiographically discernible fracture line. Fragments in close contact. Typically asymptomatic and positive response to sensitivity testing. Healing with interproximal connective tissue. Fragments appear rated by a narrow radiolucent line. Fractured edges appear rounded. Considered successful healing. Healing with interproximal bone and connective tissue. Fragments separated by a distinct bony ridge. Successful healing pattern. Interproximal inflammatory tissue without healing, widening of fracture line and/or developing radiolucency. Typical when coronal segment loses vitality. Inflammatory response due to infective products in coronal pulp. Histological aspect. Healing involves pulpal and periodontal tissues. Coronal yellowing, possible calcific metamorphosis of coronal segment. These patterns guide prognosis and management decisions for root fractures. Treatment of complications in root fractures. Coronal root fractures. Adequate splinting improves chances of healing. Extraction indicated if fracture occurs at or coronal to crest of alveolar bone. Evaluation of restorability based on level of fracture and length of remaining root. Orthodontic eruption of apical segment if restorability feasible. Midroot and apical root fractures. Permanent pulpal necrosis occurs in 25% of cases. Endodontic treatment indicated in coronal segment and less periapical pathology seen in apical segment. Long-term calcium hydride or MTA treatment indicated if wide pulpal lumen at apical extent of coronal segment. Endodontic treatment through fracture site is challenging and can affect healing. Surgical removal of necrotic apical segment viable if remaining coronal segment provides adequate support. Follow-up. At 3, 6, and 12 months, then yearly, for at least 5 years. Prognosis. Degree of dislocation and mobility of coronal fragment crucial. Immature teeth have good prognosis if involved. Quality of treatment influences repair success. Quick treatment, close reduction, and splinting improve prognosis. Complications include pulp necrosis and root canal obliteration, treatable with calcium hydroxide to stimulate hard tissue barrier formation. Luxation injuries. Definitions. Concussion, no displacement, normal mobility, sensitivity to percussion. Subluxation, sensitivity to percussion, increased mobility, no displacement. Lateral luxation, displacement labially, lingually, distally, or incisally. Extrusive luxation, displacement in a coronal direction. Intrusive luxation, displacement in an apical direction into the alveolus. Incidence. Luxation injuries are the most common dental injuries, with an incidence ranging from 30% to 44%. Treatment. Concussed or subluxated teeth, no immediate treatment needed. Monitor for responsiveness to vitality tests. Lateral and extrusive luxation, reposition as soon as possible. Physiologic splinting for 2 weeks, extrusive, or 4 weeks, lateral. Root canal therapy decision follows avulsion guidelines. Endodontic treatment for fully formed apex or apical translocation. Intruded permanent teeth, unlikely to spontaneously re-erupt. Consider orthodontic extrusion or immediate surgical repositioning. Orthodontic extrusion should be initiated promptly, not delayed longer than 2 to 3 weeks. Surgical repositioning may be advantageous with few disadvantages. Splint intruded tooth for at least 4 weeks, possibly longer. Note, vigilant monitoring and prompt treatment decisions are essential for optimal outcomes in luxation injuries. Biologic consequences of luxation injuries. Luxation injuries lead to damage to the attachment apparatus and apical neurovascular supply, resulting in altered or non-vital teeth. The severity of damage varies with the type of injury, with intrusion causing the most damage and concussion the least. Responses. Favorable healing occurs when damaged root surfaces and resulting inflammation are covered with cementum, restoring attachment. Unfavorable response involves direct bone attachment to the root, leading to replacement of the root by bone. Resorption responses involving the pulp. External inflammatory root resorption. Necrotic infected pulp stimulates periodontal inflammation, leading to root and bone resorption. Lack of cemental protection allows inflammation to affect the periodontal ligament and root. Internal inflammatory root resorption. Inflamed pulp contributes to resorption of the root structure. Necrotic infected pulp in the coronal region stimulates inflammation in the more apical parts of the remaining vital pulp. Loss of precemental protection during injury contributes to this type of resorption. Understanding these biologic consequences is crucial for managing luxation injuries and predicting treatment outcomes. External root resorption. Localized injury, healing with cementum. Occurs after mild injuries like concussion or subluxation. Inflammatory response and localized root resorption are limited to the area of mechanical damage. Periodontal healing and root surface repair occur within 14 days. No treatment is required as it is usually asymptomatic and not visualized radiographically. Avoid misinterpreting small radiolucencies as progressive resorption. Spontaneous healing can occur, and endodontic treatment should not be initiated if the pulp responds to sensitivity tests. Diffuse injury, healing by replacement resorption. Occurs after severe injuries like intrusive luxation or avulsion with extended dry time, affecting more than 20% of the root surface. Severe mechanical damage leads to an inflammatory response followed by a diffuse area of root surface, devoid of cementum. Dentoalveolar ankylosis may occur, resulting in failure of tooth eruption and replacement resorption. Replacement resorption involves the root being replaced with bone, a physiologic process termed osseous replacement. Treatment strategies aim to minimize the initial inflammatory response to the injury, potentially using medications like Lix or triamcinolone to inhibit external root resorption. Caused by injury to the external root surface and inflammatory stimulus in the root canal. Inflammatory stimuli like pulp space infection can also lead to external root resorption. Management focuses on addressing the underlying infection in the pulp space. Understanding the mechanisms and treatment strategies for external root resorption is essential for preserving tooth structure and function following traumatic injuries. Consequences of apical neurovascular supply damage. Pulp canal obliteration, calcification. Common after luxation injuries, especially in teeth with open apices, extrusive and lateral luxation injuries, and those rigidly splinted. Mechanism, unknown, but theories include altered blow control to odontoblasts and subsequent uncontrolled reparative dentin formation, or calcification around hemorrhage and blood clot formation in the pulp. Diagnosis usually within the first year after injury. Pulp necrosis. Most likely to occur after severe injuries like intrusion, especially in teeth with mature apices. Leads to infection of the root canal system, requiring treatment to prevent problematic consequences. Pulp space infection. Results in pararadicular root and bone resorption. Occurs after necrosis of the pulp due to severe injury. Bacterial toxins through dentinal tubules, stimulating an inflammatory response in the periodontal ligament, leading to root and bone resorption. Radiographically observed as progressive radiolucent areas of the root and adjacent bone. Understanding the consequences of apical neurovascular supply damage is crucial for assessing and managing traumatic dental injuries effectively. Prompt diagnosis and appropriate treatment are essential to prevent further complications. Treatment of traumatic dental injuries. Prevention of pulp space infection. Re-establish vitality of the pulp. Promptly replant teeth within 60 minutes of injury, especially in young teeth with incompletely formed apices. Soaking avulsed teeth in doxycycline or covering the root with minocycline powder before replantation can enhance revascularization. Diagnostic tools like laser Doppler flowmeter or pulse oximeter may aid in detecting revascularization as early as 4 weeks after the injury. B. Prevent root canal infection. Initiate root canal treatment 7 to 10 days after the injury to prevent quickly necrosed pulp from becoming infected. Start with chemomechanical preparation followed by intracanal dressing with a creamy mix of calcium hydroxide. Complete endodontic treatment after approximately 1 month, once periodontal healing of the injury is complete. Elimination of pulp space infection. If root canal treatment is initiated later than 10 days after the accident or if active external inflammatory resorption is observed. Conduct microbial control phase during the first visit, cleaning and shaping the canal, and placing corticosteroid/antibiotic material or a creamy mix of calcium hydroxide. Follow-up after approximately 1 month to fill the canal with a dense mix of calcium hydroxide. Assess healing and calcium hydroxide washout radiographically at 3-month intervals. Once adjacent bone has healed, assume that the resorptive process in the root has stopped, and obturate the canal with permanent filling material. Early intervention and meticulous treatment are essential to prevent infection and promote healing after traumatic dental injuries. Regular follow-ups and assessment are necessary to monitor the progress of treatment and ensure successful outcomes. Internal root resorption. Definition. Internal root resorption involves resorption of the internal aspect of the root canal by multinucleated giant cells adjacent to granulation tissue in the pulp. Etiology. Typically rare in permanent teeth, characterized by oval-shaped enlargement of the root canal. Often confused with external resorption, which is more common. Originates from pulpal granulation tissue caused by an infected coronal pulp space, communicating through dentinal tubules. Loss of perdentin adjacent to granulation tissue may be due to trauma or extreme heat during dental procedures. Clinical manifestations. Usually asymptomatic and detected through routine radiographs. Can be active even if part of the pulp is vital, often with necrotic coronal pulp but vital apical pulp. Pink tooth appearance may be present but can also occur in invasive cervical resorption. Radiographic appearance. Presence as a uniform radiolucent enlargement of the pulp canal, distorting the original outline of the root canal. Histologic appearance. Granulation tissue with multinucleated giant cells, with necrotic pulp coronal to the granulation tissue. Dentinal tube may contain microorganisms, communicating between the necrotic zone and granulation tissue. Treatment. Endodontic treatment is the primary approach, aiming to remove the blood supply to the resorbing cells. Exploration of the apical canal, thorough cleaning, and shaping are performed to cut off the blood supply. Calcium hydroxide is used to facilitate tissue removal in irregular defects, followed by warm gutta-percha filling. Treatment for internal root resorption involves meticulous endodontic procedures to remove the source of inflammation and promote healing. Regular follow-ups and radiographic assessments are necessary to monitor progress and ensure successful outcomes. Diagnostic features of external versus internal root resorption. Radiographic features. Change of angulation. Internal resorption appears close to the canal regardless of X-ray angle. External resorption moves away from the canal with changing X-ray angles. Outline of canal. Internal resorption, distorted root canal outline, contiguous with radiolucent defect. External resorption, normal root canal outline, visible running through the defect. Invasive cervical resorption. May involve resorption of both bone and root, with radiolucencies apparent in Internal root resorption is confined to the root and does not involve the bone. Perforation of root. Rarely, internal defect perforating the root may cause adjacent bone resorption, appearing radiolucent on the radiograph. Clinical examination. Pink tooth appearance. May indicate either internal root resorption or invasive cervical resorption, requiring careful evaluation to differentiate. Overall, careful evaluation of radiographic features, including changes in angulation and root canal outline, along with consideration of clinical findings such as pink tooth appearance, can aid in distinguishing between external and internal root resorption. External root resorption. Radiographs from two different horizontal projections depict movement of the lesion to outside the confines of the root canal. Internal resorption. Radiographs from two different horizontal projections depict the lesion within the confines of the root canal on both views and the adjacent bone intact. On both views. Transient apical breakdown, TAB. A variation of internal resorption, often observed after luxation injuries in more mature teeth, characterized by transient apical breakdown. Disruption of the neurovascular bundle at the apex leads to inflammatory mediators, allowing osteoclastic changes at the apex to accommodate vascular-derived repair, followed by apex remodeling once the resorptive processes resolve. Observation is typically sufficient for managing TAB, with no additional treatment required. Summary of possible diagnostic features. External inflammatory root resorption. Due to pulp infection. Apical, no responsive pulp to stimuli, with or without trauma history. Lateral luxation. History of trauma. No responsive pulp to stimuli. Lesion moves on angled X-rays. Root canal visualized radiographically overlying the defect. Bony radiolucency apparent. Invasive cervical resorption. History of trauma. Positive pulp sensitivity test. Lesion located at the attachment level. Lesion moves on angled X-rays. Root canal outline undistorted and visualized radiographically. Crustal bony defect associated with the lesion. Pink spot possible. CBCT imaging provides reliable visualization of the extent of resorption. Internal root resorption. History of trauma, crown preparation, or pulpotomy. Likely responsive pulp to stimuli. Lesion may occur at any location along the root canal. Lesion stays associated with the root canal on angled X-rays. Radiolucency contained in the root without adjacent bony defect. Pink spot possible. Misdiagnosis. Most common between invasive cervical and internal root resorptions. Diagnosis confirmation is crucial as treatment proceeds. During root canal therapy, cessation of bleeding post-pulp extirpation indicates internal resorption, while continued bleeding suggests an external lesion treatment. In internal resorption, obturation should fill the entire canal from within. Failure indicates suspicion of an external lesion perforating the root. Continuation of resorptive process on recall radiographs after removal of blood supply during pulp extirpation suggests misdiagnosis of an external resorptive defect. Clinical management of avulsed tooth. Favorable healing post-avulsion injury necessitates prompt emergency intervention, followed by evaluation and potential treatment at critical intervals during the healing process. Both the public and dental clinicians across various disciplines should be well versed in the treatment strategies involved due to the urgent and multidisciplinary nature of follow-up evaluations. Consequences of tooth avulsion. Attachment damage results from tearing of the periodontal ligament and localized cemental damage due to crushing of the tooth against the socket. Minimal consequences with hydrated periodontal ligament cells. If the periodontal ligament cells remain hydrated and viable, favorable healing occurs with minimal destructive inflammation. Repair with new replacement cementum is likely after the initial inflammation subsides. Excessive drying. If the periodontal ligament cells dry out excessively before replantation, severe inflammatory response over a diffuse root surface area. This leads to replacement resorption, where bone directly attaches onto the root surface, ultimately resulting in the replacement of the entire root by bone. Pulpal necrosis always occurs after an avulsion injury. Necrotic pulp becomes susceptible to bacterial contamination, leading to pulp space infection if revascularization or effective endodontic therapy is not carried out. External inflammatory resorption, combination of bacteria in the root canal and cemental damage on the external root surface results in external inflammatory resorption, which can lead to rapid loss of the tooth root. Treatment strategies. Treatment strategies aim to limit the extent of periradicular inflammation, thereby favoring favorable responses such as cemental repair over unfavorable outcomes like replacement resorption or inflammatory resorption. Early intervention and appropriate management are crucial to mitigate adverse consequences and promote optimal healing. Treatment objectives. Minimize attachment damage and inflammation. While attachment damage from avulsion cannot be entirely avoided, treatment aims to minimize additional damage to the periodontal ligament caused by drying when the tooth is out of the mouth. This reduces resultant inflammation and complications. Steps are to mitigate severe damage and slow replacement resorption of the root by bone to retain the tooth in the mouth for as long as possible. Promote pulp revascularization. In open apex teeth, efforts focus on promoting revascularization of the pulp to prevent pulp space infection. Special attention is given to facilitating the restorative blood supply to the pulp tissue to support its vitality and healing. Prevent pulp space infection. In cases where revascularization fails in open apex teeth or is not feasible in closed apex teeth, treatment strategies aim to prevent or eliminate toxins from the root canal space. This involves thorough root canal infection to remove bacterial contaminants and prevent pulp space infection, which can lead to complications such as external inflammatory resorption. Clinical management, emergency treatment at the accident site. Replantation or storage. The immediate action at the accident site is to replant the avulsed tooth if possible. If not, the tooth should be placed in an appropriate storage medium to maintain viability. The goal is to minimize necrosis of the periodontal during the time the tooth is out of the mouth. Preventing drying. Speed is crucial for replantation. Every effort should be made to replant the tooth within the first 15 to 20 minutes to prevent drying, which can lead to loss of normal physiological function and morphology of the periodontal ligament cells. Communication and education. Clear communication with emergency personnel at the accident site is essential. Ideally, educational offerings should be provided to school nurses or athletic trainers beforehand. If not, instructions can be given over the phone to ensure proper handling of the avulsed tooth. Storage. If immediate replantation is not feasible, the tooth should be stored in an appropriate medium until the patient can reach the dental office. Preferred storage media, in order of preference, include milk, saliva, physiologic saline, and water. Water should be avoided as it can lead to rapid cell lysis and increased inflammation upon implantation. Specialized transport containers. Specialized transport containers containing cell culture media, such as Hank's Balanced Salt Solution, HBSS, have shown superior ability to maintain periodontal ligament viability. While currently impractical for widespread use, their availability in emergencies at accident sites, schools, ambulances, and with emergency response personnel could be beneficial in serious injury cases. By following these emergency treatment protocols, the chances of a favorable outcome after tooth avulsion can be significantly increased. Management in the dental office. Emergency visit. Prepare socket. The socket should be carefully prepared to remove any debris or damaged tissue that could interfere with proper healing. Prepare root. The root of the avulsed tooth should be gently cleaned and prepared to ensure optimal conditions for replantation. Replantation. The tooth is replanted into the socket with utmost care, aiming to minimize damage to the periodontal ligament and surrounding tissues. Construct functional splint. A functional splint is constructed to stabilize the replanted tooth and facilitate healing of the attachment apparatus. The splint should provide support while allowing for physiologic movement. Administer local and systemic antibiotics. Local antibiotics may be applied to the socket to prevent infection, while systemic antibiotics may be prescribed to reduce the risk of systemic infection. Additional considerations. Evaluation for serious injuries. It's crucial to recognize that dental injuries may be secondary to more serious injuries, such as head trauma or central nervous system, CNS, injury. If CNS injury is suspected, immediate referral to the appropriate expert takes precedence over dental treatment. Focus on attachment apparatus. Once serious injuries are ruled out, the primary focus of the emergency visit is on the attachment apparatus of the avulsed tooth. The goal is to replant the tooth with minimal damage to ensure optimal healing potential of the periodontal ligament cells. By following these steps during the emergency visit, dental clinicians can optimize the chances of successful replantation and long-term retention of the avulsed tooth. Diagnosis and treatment planning. Assessment of replanted tooth. A complete history is taken to evaluate the likelihood of a favorable outcome following replantation. The position of the replanted tooth is assessed and adjusted if necessary. In rare cases, gentle removal of the tooth may be considered to optimize outcomes. Evaluation of tooth out of the mouth. The storage medium used for the avulsed tooth is evaluated, and if necessary, the tooth is placed in a more appropriate medium. HBSS, Hank's Balanced Salt Solution, is considered the best medium, while milk or physiologic saline are also suitable. Medical and accident history. Comprehensive medical and accident histories are obtained, focusing on the circumstances of the injury. Clinical examination. The socket is examined to determine its condition and suitability for replantation. It is gently rinsed with saline to remove clots and its walls are assessed for integrity. Radiographs are taken to evaluate the socket and surrounding structures, including adjacent teeth for possible horizontal root fractures. The remaining teeth in both the upper and lower jaws are examined for injuries, such as crown fractures. Soft tissue lacerations are noted, and missing tooth fragments are explored. Photographs may be taken prior to treatment, especially if legal concerns or insurance claims are involved. By conducting a thorough diagnosis and treatment planning process, dental professionals can effectively manage avulsed teeth and optimize outcomes for patients. Preparation of the root. Extraoral dry time less than 60 minutes. Closed apex. Rinse the root of debris with water or saline. Replant the tooth gently. Revascularization is not possible, but periodontal healing may occur if the dry time was less than 15 to 20 minutes, reducing the chance of severe inflammatory response. Open apex. Gently rinse off debris. Soak the tooth in doxycycline for 5 minutes or cover it with minocycline before replantation to enhance revascularization and continued root development. Treatment challenges for dry time between 20 to 60 minutes. Logic suggests that the root surface consists of some cells with the potential to regenerate and some that may act as inflammatory stimulators. Replantation process. For both closed and open apex teeth, the root is gently rinsed and replanted after appropriate preparation. By following these guidelines, dental professionals can optimize the chances of successful replantation and promote favorable outcomes for avulsed teeth, depending on the dry time and maturity of the tooth. Revascularization of immature root. A tooth with an open apex was replanted soon after the avulsion. The checkup radiograph 12 years later confirms that regrowth has taken place into the pulp chamber. It appears that a bone plug has grown in, and new periligament has formed, with a lamina dura within the pulp canal. Extraoral dry time more than 60 minutes, closed apex. Remove periodontal ligament. Place the root in acid for 5 minutes to remove all remaining periodontal ligament, which would otherwise initiate an inflammatory response upon replantation. Soak the tooth in 2% stannous fluoride for 5 minutes to enhance resistance to resorption. Consideration may be given to using Emdogain, enamel matrix protein, to make the root more resistant to resorption, but recent studies suggest its positive effect is temporary. Endodontic treatment. If no consideration is given to preserving the periodontal ligament, endodontic treatment may be performed extraorally. In teeth with a closed apex, no advantage exists to this additional step at the emergency visit. For teeth with an open apex, performing endodontic treatment extraorally may involve a long-term apexification procedure. Extraoral dry time more than 60 minutes, open apex. Replant the tooth if possible and treat as with a closed apex tooth. Endodontic treatment may be performed out of the mouth. Considerations. Pediatric clinicians may recommend against replanting teeth in young patients due to poor prognosis and potential complications. However, careful follow-up and decoronation procedures may help maintain alveolar bone width for easier restoration in the future. Preparation of the socket. Leave the socket undisturbed before replantation. Remove obstacles in the socket to facilitate tooth replacement. Lightly aspirate if a blood clot is present. If the alveolar bone has collapsed, carefully reposition the wall with a blunt instrument to facilitate replantation. Splinting. Flexible splinting. A splint that allows for physiologic movement of the tooth during healing is recommended. Flexible fixation for 1 to 2 weeks is suggested to decrease the incidence of ankylosis. Composite and wire splints with a wire diameter no greater than 0.0 mm are considered flexible. The splint should permit tooth movement, have no memory to prevent tooth movement during healing, and should not impinge on the gingiva or hinder oral hygiene. Fishing line bonded with resin-modified glass ionomer cement is a recommended splinting material due to reduced iatrogenic damage upon removal. A titanium trauma splint (TTS) has been shown to be effective and easy to use. Placement and verification. After placement, verify the tooth's positioning with a radiograph. Adjust the bite to ensure the tooth is not in a position causing traumatic occlusion. Periodontal support to maintain the tooth in position usually develops within 1 week. Duration of splinting. Remove the splint after 1 to 2 weeks, except in cases of avulsion with alveolar fractures, where splinting for 4 to 8 weeks is suggested. Management of soft tissues. Socket gingival lacerations. Tight suturing of soft tissue lacerations of the socket gingiva is recommended. Lip lacerations. Approach lip lacerations cautiously, and consider a plastic surgery, consult if necessary. Thoroughly clean the wound before suturing to optimize healing and aesthetic results. Adjunctive therapy. Systemic antibiotics. Administer systemic antibiotics at the time of replantation and before endodontic treatment to prevent bacterial invasion of the necrotic pulp. Tetracycline is effective and also reduces root resorption, affecting osteoclast motility and collagenase effectiveness. Doxycycline or penicillin V are alternatives, depending on the patient's susceptibility to tetracycline staining. Continue antibiotic therapy until the splint is removed. Control of sulcus bacterial content. Stress the importance of adequate oral hygiene to the patient. Use chlorhexidine rinses for 7 to 10 days to control bacterial content in the sulcus. Pulp management. Consider removal of pulp contents at the emergency visit and placement of Letermix or corticosteroid into the root canal to inhibit inflammatory response and dentinoclast spread. Pain management. Assess the need for analgesics on an individual basis. Typically NSAIDs are sufficient. Stronger pain medications are rarely necessary. Tetanus booster. Advise the patient to consult a physician for a tetanus booster within 48 hours of the initial visit. Second visit. Timing. The second visit should occur 1 to 2 weeks after the trauma. Focus. Emphasize prevention or elimination of potential irritants from the root canal space. Discontinue systemic antibiotics and chlorhexidine rinses. Splint removal. Remove the splint. Some tooth mobility may persist, but healing is expected to continue without it. Endodontic treatment. Extraoral time less than 60 minutes. Closed apex. Initiate endodontic treatment after 1 to 2 weeks. Long-term calcium hydroxide treatment may be necessary if signs of resorption are present or if treatment is delayed. Thoroughly clean, shade, irrigate the root canal before filling it with calcium hydroxide. Obture the canal once a radiographically intact periodontal membrane is demonstrated around the root. Open apex. Avoid endodontic treatment and monitor for signs of revascularization. If signs of infected pulp appear, initiate an apexification procedure. Regular recalls every 3 to 4 weeks for pulp vitality testing are recommended. Thermal tests such as carbon dioxide snow or dichlorodifluoromethane are effective, along with clinical and radiographic assessments. Initiate endodontic treatment and apification procedure at the first sign of pathosis in the root canal space after disinfection. Medicaments. Calcium hydroxide. Effective antibacterial agent and promotes healing. Keep changing to a minimum, not more than every 3 months, due to necrotizing effect on repopulating cells. Considered material of choice in preventing and treating inflammatory root resorption. Letter mix. Effective in inhibiting spread of dentinoclasts without damaging the periodontal ligament. Enhanced release and diffusion when used in combination with calcium hydroxide paste. Diagnosis of pulp vitality. Regular recalls every 3 to 4 weeks for pulp vitality testing. Tests with carbon dioxide snow or dichlorodifluoromethane are recommended, along with clinical and radiographic assessments. Laser Doppler flowmeter is superior but costly for average dental offices. Initiation of treatment. Initiate endodontic treatment and apexification procedure at the first sign of pathosis in traumatized immature teeth. Regular monitoring and timely intervention are crucial to prevent complications associated with pulp necrosis and root resorption. Endodontic treatment. Extraoral time more than 60 minutes. Closed apex. Treated similarly to teeth with less than 60 minutes of extraoral time. Open apex if replanted. Initiate apexification procedure if endodontic treatment was not performed out of the mouth. Temporary restoration. Essential for preventing infection of the canal between visits. Recommended materials include reinforced zinc oxide eugenol cement, acid etch, composite resin, or glass ionomer cement. Ensure a depth of at least 4 mm to achieve proper sealability. Remove calcium hydroxide from the access cavity before placing the temporary restoration. Root filling visit. Schedule at clinician's convenience or after long-term calcium hydroxide therapy when an intact lamina dura is observed. If endodontic treatment initiated 1 to 2 weeks after avulsion and examination confirms normality, root canal filling is acceptable. If treatment initiated more than 2 weeks after avulsion or active resorption is visible, disinfect the pulp space before root filling. Permanent restoration. Coronal leakage from defective restorations can lead to bacterial contamination. Permanent restoration should be placed as soon as possible to prevent coronal leakage. Composite resins with dentin bonding agents are recommended, especially in anterior teeth, for aesthetic purposes. Follow-up care. Regular evaluations at 3 months, 6 months, and yearly for at least 5 years. More frequent follow-up if replacement or inflammatory root resorption is identified. Adjacent and surrounding teeth should also be monitored for pathologic changes. Late complications. Continued monitoring for at least 5 years post-trauma. Late complications such as resorption and changes in crown color should be addressed accordingly. Dentoalveolar trauma to primary dentition. Similar classification of injuries as permanent dentition with different management approaches. Conservative treatment recommended for most luxation injuries in preschool children. Immediate treatment advised for complicated fractures and luxations, especially when permanent teeth are at risk. This comprehensive management plan ensures optimal outcomes and addresses potential complications following dentoalveolar trauma.